Now we invite Dr. ARUP CHAKRABARTI. He's going to talk about we keep seeing those cases every day. Your capsular access doesn't go in a proper manner. Then you have a difficulty in managing the cases, and you go to showcase how do we manage cases with phaco in a compromised Rhexis. Dr. Arup, please.
Thank you, Titial sir, for giving me an opportunity. So we have all heard today that phacoemulsification, a safe phacoemulsification requires an intact capsular bag, and most of the time it is intact. But from time to time, you may have situations when the Rhexis has run to the periphery. So the incidence in the literature varies from 0.79% to 5.55%. And in a Moorfield study published in the American Journal some couple of years back, the incidence of Rhexis runoff was 1.5%. And in the same study, 1.65% patients went on to develop posterior capsular rent. So the question arises, if the Rhexis runs to the periphery, do you continue with phacoemulsification or continue with a safer non-phaco technique? If you decide to go ahead with phacoemulsification, do you use the same standard technique or would you modify the technique to make the surgery safer? And then if everything goes on well, do you alter the intraocular lens decision? Because now you don't have an intact capsular bag. So I'll be addressing these questions. Nothing financial in my talks today. The Rhexis tear can happen at various stages of phacoemulsification, and I'll be talking to you about a primary Rhexis tear. That is when you're going to make the Rhexis, that time it is run to the periphery. Because management will depends upon the timing of the tear. So I'll be confining myself to this aspect. We should always also be familiar with the presence of risk factors for Rhexis runoff, and we need to have adequate preoperative discussions and counseling with the patient if these risk factors are present. Now, this was a case, intumescent cataract, very swollen anterior chamber, very swollen cataract. Now, I'm not going to talk about what went wrong and how the Rhexis tear could have been prevented. Dr. Ramamurthy have covered some points here, and there are a couple of other points. So my talk is not on that today. And my talk about on that is the Rhexis tear is happening, and in spite of my best efforts, like I lost control with the capsulotomy needle, cystitome, and then I tried to regain some control with the Rhexis forceps, but then still it ran to the periphery, as you see here. Now, what do we do? Okay, now in terms of phacoemulsification. So I decided to perform a phacoemulsification in this case. It was not a very hard cataract. It was quite a brittle nucleus. So before that, you need to ensure that there's adequate access to the capsular, to the nucleus, which means there should be adequate anterior capsular opening. There should not be any dog earing of the capsular flap because they tend to come to the to the nucleus, to the phaco port. So hydrosteps need not be done in these cases. Particularly here, there's no point in doing hydrostep. There's no additions that are expected. And some surgeons believe in giving a balancing cut on the 180-degree periphery away. I don't do that, but then there is a school of thought that it may help. So here, I am going to use a higher power than that is necessary, because I do not want the nucleus to be moving around in the capsular bag and in the process stressing out the capsular bag. So if I, let's say, decided to use 50% for this case, starting phaco power, I'll be using maybe 60% or maybe a little higher than that. So scalping has to be very sufficiently done, very safely done. We don't want the nucleus to be moving around. So here we have a capsular opening. I thought that is adequate. We don't want to make it too big. As such, there's an opening so the nucleus content may come to the anterior chamber, and you don't want to be doing anterior chamber phaco as far as possible. So here I'm using a little higher power, go as deep as possible, the central short trench, then start chopping. Now elevate the nucleus a little bit, float it up in the capsular bag. No manipulations should be transmitted to the posterior capsule and via that to the peripheral areas. So as you see here, in spite of my best efforts in confining the manipulations within the capsular bag, the nucleus tends to come to the periphery, comes to the anterior chamber because of an opening present here. So you need to top up the anterior chamber with frequent injections of dispersive OVD to protect the corneal endothelium. Now, if you are using a divide and conquer kind of technique, a stop and chop kind of technique, make sure that your lateral separation is located as far away as possible from the Rhexis tear that has happened. So anyway, we won't prefer to use a divide and conquer technique or a stop and chop technique here, and chopping will be ideal in my hands. The technique, of course, depends upon the surgeon. Another thing that is to be remembered is if you're rotating the nucleus, you have to be very, very gentle. Everything should be done as if it is happening in a slow motion, maintain the anterior chamber depth. Rohit Om Prakash has published a paper on the capsular flap motility sign, And I think one has to keep looking at the capsular flap, which direction they are moving, and which they're inverted or reverted, and that may give an idea about whether it has become a wraparound tear, and you may have to modify your surgical technique depending upon that. So it is nucleus management actually was not an edited video, so whatever it is shown on time, and and you have to avoid the last minute surge, because the occlusion break that happens in the last piece is nucleus is removed. So we don't want the AC to be getting shallow here. So inject OVD from the side port. Cortex removal, one has to be very careful, because the moment you go towards the area of the Rhexis tear, you may stand the risk of catching the capsular flap, and then may be problem. So here I have changed my plan. Actually, I decided to use a hydrophobic 3-piece hydrophobic acrylic lens. The leading haptic, if you wish, you can deliver it in the anterior chamber in front of the iris to start with. But here I was pretty confident, so I ensured that the leading haptic just grazes the anterior capsule and lands up in the ciliary sulcus. But I'm going to keep the lens in the ciliary sulcus, the haptics, and the optics is going to be captured. It is not going to be a 360-degree capture, the typical capture that we talk about, posterior optic capture, buttonholing or locking the lens in place. But then I have had the experience of using this technique in Rhexis runoff of more than 10 cases, and none of them have got clinically decentered in the postoperative period once the asymmetric capsular bag contracture happens. So the lens actually was kept in the sulcus, optic is in the bag, and that is the end of the surgery. So patient did well, and this is the first postoperative day. You see the Rhexis tear that is going to the periphery on the nasal side, absolutely crystal clear cornea, patient had normal vision. So basically, I mean, I would like to tell you that place may take maximum care to ensure that your Rhexis is intact. Sometimes, very rarely, it may not happen that way. So what you do subsequently depends upon a number of factors. Surgeon experience is very important. Now, I have been doing phaco for last 30 years. So if I have a Rhexis tear opposite to my clear corneal incision, and it's a very hard nucleus, grade 5, grade 6 cataract, nucleus sclerosis, shallow anterior chamber, compromised corneal endothelium, etc., pseudoexfoliation, I would convert into a small incision cataract surgery procedure. But if you have the confidence, you feel that you can go ahead. So location of the tear, timing of the tear out makes a lot of difference, plus absence and presence of the comorbidities. Now, if you are a young surgeon on your own, or you have a senior surgeon in the same operation theater, you can always ask for help. There is no harm in handing over the case to your senior colleague, or to referring the patient out to your friend who is a private practitioner, because at the end of the day, the patient is not going to thank you for the courage that you have shown to create complications. The patient is going to thank you for good results, for your good judgment, for your wisdom in referring the patient out at the right time. So in these cases, phaco can still be performed, but you need to be aware of the facts that I have mentioned. We would like to perform an endocapsular phaco, but at times nucleus comes anteriorly when we end up performing an iris pen phaco. Avoid antechamber phaco as far as possible. Use an appropriate intraocular lens. Now, if it was a toric lens, I would have definitely gone ahead and used a toric lens. But multifocal lens, again, I'm not too sure how the contracture is going to affect the final optics of the eye because of the multifocality of the lens. So perhaps if it is a trifocal lens, I am not sure whether I would be going ahead with the same plan, or would like to change the lens to a different type of lens. So friends, a good phaco is possible in Rhexis test situations. Conditions apply, and if you use the proper guidelines and manage the nucleus properly, you're going to come out with flying colors. Thank you so much for your attention.